Hi. So I am Dr. Hala Kandil, microbiology consultant and antimicrobial lead for West Horse Hospital. This is my colleague Tejal Vagela, antimicrobial pharmacist in our trust. So our project is called CASP. And CASP stands for Comprehensive Antimicrobial Stewardship Program. And the reason why we called it this way is that we think that in order to implement a sustained improvement in antimicrobial stewardship, you need to have several interventions, perhaps running all together, and each of these interventions will tackle or address an aspect of the AMR. So that's why CASP. So CASP focused mainly on the three strategic aims of the UK AMR strategy. And also the interventions we've implemented actually focused on some of the key areas and actions also recommended in the same document. So, for example, we have implemented this 2 years ago now, and one of the components is better use of surveillance data. So what we did is we introduced a surveillance data for local epidemiology, resistance, prevalence. That has informed our local antibiotic guidelines. So we were able to get our unnecessary antibiotics from the guideline, redundant antibiotic, and also enabled us to use narrow-spectrum antibiotics in combination to preserve broad-spectrum antibiotic, for example, coamoxiclav and gentamicin. So, and also that has provided an evidence to the clinician, so our advice is actually evidence-based. So the second component was about antimicrobial stewardship world-round, and I need to kind of mention Tejal for her excellence, exceptional work in this. That has resulted in actually major reduction of antibiotic use. We reviewed our practice during those world rounds, and out of all the antibiotic that we have reviewed and actually stopped or switched, none of those patients has been restarted antibiotic for the same infection, and also there was no readmission within the 28 days for the same episode of the infection. So that has given us an assurance to us and to the clinicians that we are doing the right thing, because obviously patient safety is paramount. Another component is we realized that it is very important. The collaboration with clinician is the key for success. So we started to implement multidisciplinary team working, and the first one we've implemented is sepsis team. So we have a dedicated sepsis nurse on board. We have recruited all the consultants in different specialties and matrons, and we have established a good sepsis team, and we had major improvement, significant improvement, especially in terms of starting IV antibiotics within an hour. And we've met the sequin indicators. So we didn't stop at this point, and we have introduced the rapid diagnostics. And in rapid diagnostics, we introduced it during the winter season, lab-based testing, and we have managed to reduce antibiotic by 1.2% during the winter season. Finally, we wanted to engage the public. So we've engaged our clinicians, but also medical students, because we believe that at an early stage of their practice, they need to understand the AMR problem. We've engaged also primary schools. So we went outside and we have visited primary schools, and we've given them some education regarding AMR. So future plan, obviously there is a major challenge here, because in order to sustain improvement, especially when you talk about behavior changes, you need really to work hard. With limited resources, it's very difficult. The next step is rapid diagnostics. We already have implemented this as a point of care testing for viral, and we have a good result so far. We are in a process of analyzing these results, because it has major impact on improving the infection control as well. We're going to introduce new rapid diagnostics for gram-negative resistance as well, and we're going to also go to the public, and next month we're going to visit the secondary schools.